All right, perfect. So we're going to go ahead and start with our session for today. It's a pleasure to have you guys join us again. Today's topic is one that's really an essential part of every stage of the management of a surgical patient, basically. We've gone through so many topics covering surgical presentations and diseases. But when it comes down to it, the management of those diseases boils down to the workup strategy, whether it's the labs to order, the imaging strategy, or just the general management course. So it's an honor to have Dr. Rebecca Andraos with us today to take us through a glimpse of the essential workups in surgery. Dr. Rebecca Andraos is a fourth-year general surgery resident at the American University of Beirut Medical Center. She received her MD from AUB in 2016. Her specialty of choice is neck surgery and critical care, and she currently holds the position of the Vice President at the RSO Resident Staff Organization at AUBMC. So before we begin, I'd like to remind you all to keep your microphones muted and to specify any questions that you might have throughout this session in the chat box. We'll be going over them towards the end of the session. So at this point, I'll leave the rest to Dr. Andraos.
Thanks for having me again. Thank you, Rasha, for the introduction. I'm not sure if you guys are testing me with this topic or what. Just a sec so I can share my screen. So I thought the first topic he asked me to cover was challenging. Here comes the second one. That's tough to discuss in an hour because it's situation-based, but I'll try to go over the basics and over the most common things that we encounter, at least in surgery. A lot of things may be more common in medicine. I'm not going to go through that or other subspecialties. And I've noticed that the latest lectures you're having are really subspecialized. We're going to go back to a general topic today. And it kind of tags along the perioperative management that we already covered in the first lecture that I presented, if you guys have seen that. So things I'm going to be presenting today are attached to that concept. So I'm going to go first through the principles that I think are important for you in order to be able to decide when to order, what to order, on which patients, and which situations. Please feel free to ask all the questions you have at the end. I feel this session is going to be more beneficial to answer your questions specifically, but I'm going to go over the principles at first. So I called this presentation diagnostics just because I'm a huge fan of house and just because it is what it is. So whenever we are looking for a test to diagnose something, whenever we are looking for an answer, then we should have a question. So I'm going to just start by saying that it doesn't make sense for us to have an answer if we don't have a question. That's why it doesn't make sense to order any diagnostic test on a patient, whether it's a lab test or an imaging, if we don't have a question to answer with that test. So this is the first principle I'm going to start with in order for you to have the thought process of what you're going to order on your patient, which patient, before or after which surgery, is to have a question for which this test is supposed to answer. Okay? So whenever you have a question, you'll look for an answer. I'm going to go over the rationale of testing, very brief guide of the tests needed before a surgery or during or after surgery, and then I'm going to go system-based, just like the previous lecture we talked about, and some take-home messages, and I'll leave the floor for questions. So first of all, if you come to think about it, whatever rotation you guys go through, whether it's obstetrics, gynecology, internal medicine, surgery, you're asked to order labs on your patients. Pre-op, post-op, intra-op, someone who's coming in for pneumonia, someone who's coming in for gastroenteritis, order CBC Chem9. So this has become a habit. Become a habit for us if a patient is in our hospital or institution, that we have to prick him every day, take some blood, and just look at it. So studies have looked at if this habit's actually beneficial for patients. It has been shown to be of little benefit to those who have no prior past medical history, or for those who have no change in their status, even if they have past surgical, past medical history, for those who have nothing active to look for. So basically for those who we have no question to answer, okay? Basically, there are several arguments for avoiding routine testing. Normal test values are usually arbitrarily defined as those occurring within 2 standard deviations from the mean, thereby ensuring that 5% of healthy individuals who have single screening test will have an abnormal result. This is just statistics. So the more tests you order on your patient, the likelihood of a false positive test increases. Let's say if we have a screening panel containing about 20 independent tests on a patient who has no diseases, yield at least one abnormal result in 64% of the time. So imagine you're asking for tests for your patient who will have a false result in more than 0.5% of the time. That's where you have to really understand how what you're ordering will influence your perioperative management. Your management in general is perioperative because we're looking at things through the surgical perspective. So how much this input will influence my perioperative management? Am I going to act upon the result that I'm going to get? Do I want to? Is this going to benefit my patient? Does this fall into the importance of prepping my patients through the procedure that I'm prepping my patient for, or whatever medical problem patient is admitted for? So these studies have shown that most of the tests that are routinely ordered with no reason add unnecessary costs to the patient. Some of them are risky, and then we're going to talk about some invasive testing that are risky. And some will delay the surgery for no reason. Some will lead to ordering further testing in order to understand why this lab value is wrong, and this will show no benefit or will add no benefit to the operative care and preparation or post-operative management. So in order for us to know which lab to order, when, on which patient, first we have to formulate a question that we need to answer. Then, whenever we formulate that question, we decide which test we want to order. We have to understand this test. So understand the limitation. What am I looking for? What affects my result? What can give me a false positive, a false negative? What's the optimal situation to order this test in? What's the optimal sensitivity, specificity of this test to answer my question? And definitely look at the risk and cost of my testing. Some papers have suggested some sort of a guide or a panel to apply on patients preoperatively mostly. So basically they talk about if it's a minor surgery, if the age is below or above 50, what's the functional score of the patient. All of those we mentioned already in the perioperative management. I'm not going to go over them again. So we talked about meds, we talked about the comorbidities. So this is just like a guide, like a rough paper on what to do if you have no idea what to order. The basics that usually people are used to ordering, I'm going to talk about habit again. CBC, EKG, electrolytes, kidney function, glucose, the coagulopathy panel, some iron studies. So this gives an idea to whomever is just want to order labs on the patient out of the blue. So if you have, for example, a patient with hypertension, they suggest that you need to order an EKG. Okay, so this is like when you're thinking out loud. But I don't suggest a proper guide for all the patients, because as I already mentioned, this is situation-based. So this is just a rough idea. Another suggested guide talks about each blood test or each intervention or diagnostic test when is important to have it. So this is like a quick summary. However, some cases will not fall under this quick summary. So that's why you need to understand the concept of each test and the concept of testing. That's why you can apply it anywhere. Okay, so I like this quote: when we don't find a logical answer, we settle for a stupid one. Ritual is what happens when we run out of rational. So I don't want you guys to test your patients because it's a ritual, because we're used to ordering CBC and Chem9 every day. I want you to test them because it's rational, because it makes sense, and because it answers a question. So what is our question? Pre-op, usually we need to assess our patient for pre-existing comorbidities. Comorbidities are in check. Second, we need to detect any unrecognized disease that might affect our intervention or our procedure. Then we need to assess the risk factor. That depends on the procedure and the anesthesia type. So just a quick example, if my patient has diabetes, I might want to order an HbA1c before a major surgery. If my patient has some, I don't know, maybe symptoms of hypothyroidism but has never been diagnosed, I would order thyroid function test before my procedure to detect any unrecognized that put my patient in danger throughout the surgery. Other risk factors, for example, if I'm going for a regional block, it's very important for me to check the coagulation pattern of my patient, to check the risk of bleeding, the risk of my epidural puncture, etc. Intraoperatively, very limited tests that will really be of use intraoperatively. So usually if we're having a major blood loss, a major fluid shift, we would like to make sure that we're monitoring the hemoglobin of our patient, the electrolytes, and sometimes we follow the lactic acid. We will talk about this later. Another intra-op test that is usually needed also is a parathyroid hormone level whenever we're doing a parathyroidectomy, for example. We will also talk about this later. Post-op usually depends on the procedure. So what are my post-op expectations for my patient? If I'm done today with a certain procedure, what am I expecting my patient to need tomorrow? So which labs am I going to order? Is my patient eating? Do I need to monitor the electrolytes because he's NPO? Do I major blood loss? Do I need to take a hemoglobin? Is my patient on heparin drip? Do I need to follow up the PTT? So depending on the procedure, what am I expecting? I need to think of what to order on my patient. What are the in and outs? Is my patient losing a lot of fluids? What are the events that I'm expecting them to happen? Okay, so this is the thought process that I need you guys to be in before we go into each testing in particular. Definitely, before anything or any decision on the patient, we go back to the basics. As we mentioned before in the perioperative management talk, we need to know our patient very well, and this will define every step we take towards the management of our patients, let alone the diagnostics. So it's very important to know what problems my patient already has, on what medication he's on, if he has certain symptoms that are emerging around the time of the procedure, or preoperative or postoperatively, if my patient has certain symptoms that would suggest for me the need to order a certain test. So history, physical exam, again and again and again. This will be always where your basic step in anything or any decision about your patient. So whenever you're talking to a healthy patient, no past medical, because usually a very sick man or a very sick lady will suggest your management throughout their comorbidities. All right, we know patient's diabetic, we know he's hypertensive, we know he's cardiac. So it goes without saying that you need to assess these risks. However, the big question comes on a patient who is previously healthy. So what am I to expect? What should I screen for? So this is a suggested quick screening for patients who are previously healthy, who are coming for elective surgery, which can propose to us or can help us think what we need to test our patient for. So if they're presenting for an elective surgery and they mentioned that they recently had, for example, kidney stone episode, and I need to think about hypercalcemia. I need to check if my patient has any problems in there, any new symptoms of angina. I need to go for a proper cardiac workup. Any signs or symptoms of liver disease, I need to assess for that. So just because the patient tells you that they're previously healthy, it doesn't mean that they're medically previously healthy, because a lot of patients have symptoms that they ignore, have emerging diseases that they haven't been diagnosed with yet. So we need to screen, make sure that we don't need extra testing on top of the testing needed to assess the patient's already existing comorbidity. So you already know about me. I am a fan of critical care, and we go system by system. So we're going to go again system by system, mention the most commonly ordered tests, when to order them, pre-op, post-op, intra-op, and talk about how to. First and foremost, cardiovascular system. So we talked in the previous lecture on perioperative management about risk assessment. Okay, so I'm going to go over a few concepts maybe we already talked about. EKG. So studies and guidelines do not suggest ordering EKG on asymptomatic patient coming to do a low-risk procedure with no previous cardiac history. Okay, so let's say a 30-year-old patient, previously healthy, no symptoms, coming in for a lipoma resection. You don't need an EKG. So just because everyone orders an EKG, or you see in the admission slip the EKG is always ticked doesn't mean that you have to order EKG in all patients. So you always have to put your critical thinking eye and really assess, do I really need this test, and why am I doing it? What question am I answering? So important EKG abnormality in patients that are younger than 45 with no known cardiac disease are very infrequent. So whenever you're ordering that to your patient, you're just ordering a test that you don't need. Okay, so the guidelines recommend pre-op testing of a 12-lead EKG for patients with known coronary artery disease, significant arrhythmia, peripheral arterial disease, cerebrovascular, or any other structural heart diseases, except definitely if we're going for a very low-risk procedure. The perioperative resting EKG can also be considered for asymptomatic patients undergoing elevated risk, even if they don't have cardiac disease. So let's say I'm going for general anesthesia for a surgery that's going to last 8 hours with a major fluid shift. My patient is 50 years old with no specific cardiac symptoms. It is better if I have a pre-op EKG in case we have any complications. Obese patients are another set of patients that we would like to have a pre-op EKG on, because a lot of time they mask cardiac problems. So if we have a normal EKG and we don't have any symptoms of functional problems or symptoms of cardiac failure, we don't need to go for an echo. However, if my patients come with a new onset lower extremity edema, maybe fatigue, some shortness of breath, and they're not diagnosed with heart failure, I would assess them with an echocardiography. This is not only needed pre-op for the load of the anesthesia and load of the surgery, but will also guide us through how you can manage your fluids patient. So how much can I hydrate my patient if I have heart failure or not? If it's hypotensive, what's the threshold for me to use pressors? Which pressor to use? So all of these are important for me to know beforehand what are the cardiac status of my patient. But if he's previously healthy, change on EKG, no suggested symptoms, and no history, echocardiography is not really important or is not recommended preoperatively. Definitely, if we're going to talk about stress tests and cardiac cath, these are specifically whenever we have changes on EKG and echocardiography and very suggestive symptoms for the patient. I just mentioned them because I want you to think about testing that have risks. So cardiac cath is a very risky procedure. We can't just order it on patient. Sometimes we take the lab test and then EKG, for example, for granted because there are no major risks. Keep in mind, there are some testing that have major risk. And sometimes if you do an EKG on a person with no risk on which EKG is not recommended, and then you find some non-specific changes, and then you end up doing a cath, and then you have a cath complication, and all of that was for nothing because the patient has no cardiac problem, then this is a major mistake that you've done towards your patient. That's why it's very important to know when and where to order these tests. Obviously, intraoperatively, the patient is always on a monitor, so we can intraoperatively everyone gets an EKG, not a 12-lead EKG, but some sort of EKG monitoring. And this is important because anesthesia load and all the fluid changes and blood losses in surgery will affect your heart. So intraoperatively, we always need this type of monitoring. Echo, stress test, and cath, obviously, we're not going to use them intra-op except cardiac procedure. So any cardiac procedure will have an intraoperative echo. The others are not intraoperatively used. Post-op, obviously, we need them whenever the patient presents or complains of any cardiac event or chest pain. Other than that, there's no need for ritual or daily EKG, for example, unless, again, it's a cardiac procedure and you are in CCU or something. The second cardiovascular test I want to talk about is troponin. So we all know troponin is a muscle protein which affects muscle injury in the heart. What we need to know is definitely when to order it. And I think it's one of the basics. I'm sure you already all know that whenever you have any symptoms suggesting MI or EKG changes, you go for troponin. What I need you to know is trending troponin is the important part. So don't forget to trend your test. So you know when to order it, know when you have to repeat it, and know your limitations. For example, troponin is falsely elevated in kidney failure. So if you have a patient with kidney failure and present with symptoms of MI, and then you have a high troponin, then of what does that mean. Okay. Third thing I'm going to talk about is lactic acid. So in surgery, we use lactic acid a lot. I'm not sure if you're familiar with this test. Lactic acid reflects anaerobic respiration. Usually reflects hypoperfusion of tissues. The concept of lactic acid that you need to understand, whenever you expect hypoperfusion in a patient, let's say a patient is hypotensive, he's anuric or decreased level of consciousness, all of those that reflect hypoperfusion of end organs, you need to order lactic acid. Or let's say a patient presents with to the ER with symptoms of sepsis. We order lactic acid. Why? To assess the perfusion of the organs, see if the patient his blood pressure is good enough to get blood into his organs, so not to have damage or injury to any of those organs. So the basic concept about lactic acid is production and clearance. Okay, so whenever you order this test, you need to know that it might be high because of high production, because of hypoperfusion, or because of decreased clearance, which might be a liver issue. So whenever you order it, you have to know that you're ordering it to test for hypoperfusion. You can't just take lactic acid without really understanding what you're looking for. Because if you have a high lactic acid and you don't know the status of your patient and his liver status, for example, you might have you might take a wrong decision in management. The other thing that you need to know is some drugs affect your testing. So lactic acid, for example, if your patient is on epinephrine accelerates the production of lactic acid. So sometimes when you are taking lactic acid in a patient who is hypotensive, septic, on pressors, suddenly you had to start a second pressor, which is epinephrine, because your first line will be norepi. And then suddenly lactic acid rises, and then you think your patient is becoming worse. You need to keep in mind the limitation of your testing. Okay. Again, lactic acidosis sometimes might be falsely elevated, and sometimes it might be falsely normal. So a lot of times the patient present with, for example, an internal hernia with bowel compromise. So lactic acid is another test we use to assess for bowel compromise. Why? Because it's one of the states of hypoperfusion. The bowels are not getting enough blood, so they secrete, they go into anaerobic respiration, secrete lactic acid, and it comes back in the blood. But sometimes, for example, like internal hernia, all the blood supply is twisted, and then it's just in the internal hernia, and there's no flow back to the systemic circulation. So lactic acid might be locally high, but if you take it in the patient's blood, it might be falsely reassuring. So that's another thing you need to think about. So if you have highly suspicion of hypoperfusion in your patient and you have low lactic acid, take that with a grain of salt. I'll move on. Pulmonary diagnostics. Chest X-ray is a very common tool we use in our diagnostics. So when do we use it in surgery? Definitely, again, it's not recommended for all pre-op patients. Chest X-ray is recommended if you have a smoker patient, a patient with symptoms of heart or lung disease, history of heart and lung surgery, more than 70 years old, or if you have a major surgery in the chest or upper abdomen. Okay, so routine pre-op chest X-ray is not recommended. Okay, only with patients who have certain reason for that. Another thing for ordering pre-op chest is that, or any chest X-ray, is that we have to know how to read it. So don't order something you don't understand how to use it. Okay, so that's a pre-op chest X-ray. Intra-op chest X-ray, or intra-op fluoroscopy, sometimes we call it. So whenever we are inserting lines, polycytes, non-tunneled dialysis catheter, tunnel dialysis catheter, we use intraoperative X-ray to make sure that everything is in place. Okay, that's one of the uses of intraop X-ray. Sometimes they use it in orthopedic procedure to make sure they align the fracture properly. They use it in urological procedures to make sure that the double J, for example, is in place. So these are some of the intraoperative use of chest X-ray. Post-operative chest X-ray is important in patients definitely who have inserted a line or an NG to make sure that they're in place. Although NG we can clinically test it, but this is always just to mention for completion that it might be used for that purpose. Second, and more importantly, we test for the patient's congestion. I don't know if you've seen a similar case. So we want to see the lungs if they're congested, if he has pleural effusion, definitely if the patient is suffering from desaturation, signs of atelectasis, signs of pneumonia, for chest x-ray first. So don't order chest x-ray every day on your patients post-op unless you have a reason for it, okay? Because otherwise it's just radiation for nothing. Specialized test, which is the pulmonary function test. That's not a usual test that is ordered. Definitely we don't use it intra-op and rarely post-op for any reason. Pre-op is the more important use of it. Whenever you have a patient who's coming for a lung resection, you need to know that your patient will have enough lung after you resect whatever you want to resect. So you go for PFTs to understand the lung volumes and if the patient can survive with the volume you're going to leave them with. So this is where PFTs are important. Another place where PFTs are important are patients who present with COPD and on whom you want to make sure if it's worsening, you want to make sure if the patient will be able to be extubated post-op or not, or any patient who presents with dyspnea and respiratory symptoms that are not explained by routine and basic pulmonary assessment, then you have to go for PFTs. Another common test that is ordered are arterial blood gases. We can also talk about this. We can join them to the cardiovascular system. So arterial blood gases usually tell us about the acid-base status of our patient, the O2 concentration, CO2 concentration in the blood, the base excess. So all of these are important in a patient on whom they have signs of acidosis, alkalosis. So intraoperatively, the use of arterial blood gases is the most common. Why? Because it can really reflect the fluid shift of your patient. It gives you a fast hemoglobin level. It gives you a fast electrolyte level. Preoperatively, we rarely use it only if the patient is presenting with an emergent surgery, someone who's septic, someone who's not doing well, or someone who's presenting for pulmonary procedure where we need to assess or have a baseline on the blood O2 level so we can compare post-op. Intra-op is mostly used in post-op for patients who show decreased level of consciousness, who I'm expecting CO2 retention on, who I'm expecting maybe a pulmonary embolism. It might show a certain pattern that would suggest that. Whenever, sometimes also we take lactic acid and it's high. Also, you need to know if your patient is compensating in terms of pH. So you need to know if this lactic acidosis is compensating or your patient is really acidotic and you need to do something about it. So here comes the ABGs. So again, do not order tests if you don't have a question to answer. I'll move on to the nephrology part. Chem9. I think we order Chem9 more than we talk to our patients. Again, we don't have to check the chloride level on our patients every day. Actually, come to think about it, when did we ever look at the chloride level? We order it every day in Chem9, but did we ever look at it? So I don't remember the last time I looked at my patient's chloride. So preoperatively, as well, kidney function and electrolytes are not routinely recommended in patients who are coming previously healthy, no kidney issues, and coming for an elective low-risk procedures. Obviously, if you're coming for a high-risk procedure, prolonged, which can take a long time with expected fluid shift, you need to have basic chemistry testing before the operating room. Definitely a patient who has a history of kidney problems or a patient who comes with symptoms and signs of dehydration and electrolyte disturbances. Intraoperatively, also it's one of the tests that we use whenever, for example, the patient loses a lot of blood, a lot of fluids, the urine is on the low side, then we have to make sure that our electrolytes are in place. Basically, fluid shift is what affects your electrolytes mostly, and this is when you have to think that they might be disturbed and you have to check for it. Postoperatively, in surgery in particular, they're very important because a lot of our patients in major surgery, especially major GI surgery, will be NPO. We talked about NPO last time. So in order for you to manage their maintenance electrolytes, you need to know what are the basics. And in order for you to to know your fluid status, you need your creatinine and you need your BUN. So CAM9 is a test that we use a lot in surgery, but again, if you don't need it, for example, a patient who's coming for breast surgery and has no previous kidney problems and is not coming with symptoms suggestive of electrolyte imbalances, you don't need a pre-op CAM9 on her. You don't need an intra-op CAM9 on her if everything went well, and you don't need a post-op CAM9. So the patient can come in, come out without knowing her creatinine, and that's totally fine. That's actually recommended. Okay. Another test I want to talk about in nephrology is the CPK. So CPK is one of the tests that we order whenever we have crush injury and whenever we're suspecting reperfusion injury leading to rhabdomyolysis. So this is a very important test that will guide our management, basically in those situations in surgery. And then you have to trend it post-op to make sure that it's trending down. Otherwise, you don't need an intra-op, and I don't think of any other reason that you might really need it in surgery. Urine studies, phenolphthaleura, another test that will guide your fluid management. If you've noticed, fluid management is very essential in surgery. It's something that you need to keep in mind. Any diagnostic that will help you answer a question on fluid management, you're going to be using it in surgery, pre-op, intra-op, or post-op. So phenolphthaleura, obviously, if the patient doesn't have urinary problems, you don't need it pre-op. So if the patient comes in, his urine is okay, and usually we don't monitor the urine pre-op because patients coming from home, if there are no symptoms suggestive of an issue, you're not going to think of urine studies, and we don't use it intra-op. Mainly, urine studies are used post-op for patients who show signs of dehydration, decreased urine output. So you want to know if it's pre-renal, renal, post-renal, anyone who presents with kidney injury, increased creatinine. So this will help you answer your question. Is my patient dehydration, does he need fluid, or is my patient in kidney injury because it's drug induced or because of the contrast I gave him yesterday in the CT, assessing or preparing for my surgery, etc. So these are things we use mostly post-op whenever we have decreased urine output, increased creatinine, to know which way to follow in terms of management. Myoglobin is another test, urine test that is joined to CPK whenever we have a crush injury or we're expecting rhabdomyolysis, and urinalysis, the famous urinalysis. So every patient that comes in PAU has an UA order for I don't know what reason. So basically, routine urinalysis is definitely not recommended. Theoretical reasons to obtain pre-op urinalysis is to detect an unsuspected urinary tract infection, only useful in urological procedures because you're manipulating the urological tract. So if you have an infection, it will cause a transient sepsis and it will lead to problems. Another reason is if you're putting a prosthetic, any prosthetic foreign body. Otherwise, a patient who's asymptomatic, you don't need to check their urine. And if you check the urine, if you order a urinalysis on a patient who's coming for breast surgery, for example, on whom you're not going to put implants, and then you have a positive urinalysis and the patient is asymptomatic, then what are you going to do with that? Are you going to give her antibiotics? Is she symptomatic? Maybe she has some sort of frequency, but maybe that's her baseline. So you're just ordering a test that would lead to further testing, maybe delay of surgery for no particular reason. Intraoperatively, definitely we don't need to use the urinalysis. Postoperatively, only if the patient has symptoms. Otherwise, you do not need to go for an UA. Symptoms, I mean your urinary symptoms, or if the patient is going into an infectious process for which you don't have an obvious source, then you need to test your patient for all obvious sources. One of them is your urine. Again, I will mention it 1,000 times during this talk. Understand your tests, okay? So whenever I say urinalysis, understand the component of it. It shows you the pH of the urine. What does it mean? It shows you the specific gravity, glucose, protein, ketones. So we usually just look at bacteria and white BC just to see if there's an infection, but analysis can tell you way much more than that. Okay, so understand your tests to know when you can use them. I'm not going to go into this because it's going to be very specialized, talking about when and where to order. It's more in the nephrology department, but for surgery, I covered when do we need to go for a urinalysis. White count. everyone gets a CBC. We're going to talk about hematology and if really everyone needs a CBC pre-op, intra-op, or post-op. Everyone gets a CBC, so we know the white count on everyone. We need to know the white count on everyone. So basically, someone who's presenting for an elective surgery, previously healthy, no signs and symptoms of infections, do we need a white count baseline to compare post-op? So the frequency of significant unsuspected white blood cells is very, very, very low. Okay, so unlike the hemoglobin concentration, there is little rationale to support baseline testing. Nevertheless, obtaining a complete blood count, including the white count, can be recommended only if the cost is not substantially greater. So if we need the baseline hemoglobin, if the hemoglobin and white count doesn't really matter in terms of cost, remember we talked about thinking of cost before ordering the test, then it's okay. But if I need a hemoglobin and then the cost is really different if I'm going to get a CBC, then I need to think about it. I need to think if I need a baseline white count. So if my patient is not infected, my patient has not been through recent chemotherapy for which I expect my patient to be neutropenic, for example, why do I need a white count? Okay. However, if patient presents with diverticulitis, for example, appendicitis, cholecystitis, any infectious process, then I definitely need the white count to guide my management. Intra-op, we don't use it. Post-op, if you have a high white count pre-op, then you need to trend it down. And sometimes we take a white count post-op as a baseline because surgery will increase your white count regardless as just a reactive to our intervention. So it's important to know post-op day one, what's my white count? Because let's say someone presents with a white count of 6,000 pre-op and then on day 3, he has some, I don't know, maybe cough. So I need to check if this is an infectious process. I take the white count and it's 12,000. So if I compare the 12 to the 6, which is pre-op, I'm going to say definitely my patient is cooking something. However, if I had the post-op day 1, 15,000, then I would know that this is trending down and this is post-operative. Maybe it's not an infectious process. I would cool down on antibiotics, maybe assess more, increase my diagnostics before I take a decision. So this is the importance of white count post-op. Definitely, if you have any symptoms suggesting infectious process, you need the white count. I'll go to procalcitonin. So this is a diagnostic test that emerged recently, and by recently I mean a few years, definitely not yesterday. So it's a testing that will reflect systemic bacterial infection, and it will give you the probability of your patient being in sepsis. Usually it does not change within 48 hours. So ordering, if you're suspecting on your patient an infectious process and you need to rule out if it's infectious versus inflammatory, for example, you order a procalcitonin and then it's high. And then you have to order it to see if it's trending down to guide your antibiotic treatment. You don't repeat it the next day because there's not going to be major change. So within 48 hours, you're not going to see change even if your patient is improving. So you have to know pre-op, we will not use Procal unless the patient is coming already septic and we're suspecting inflammatory, infectious process. Pre-op, definitely, it's not useful. Post-operatively, whenever your patient has infectious complications, you think about procalcitonin. And if you want to trend it, you trend it every couple of days. CRP is an acute phase reactant. Please use it with caution. The most use of it in surgery, when we need it pre-op and then we trend it post-op, is whenever we have an anastomosis. Some studies say that in a slight or a very subtle increase, sometimes within a certain context, will suggest that the patient maybe has a leak on anastomosis that we've made. But otherwise, you have to really order it very, very cautiously because any infectious or inflammatory process will increase your CRP. So if you don't have a baseline CRP, it's not really useful. The trend of CRP is more important than a single reading. And if your patient, for example, on post-op day 3 is presenting with abdominal pain and you take a CRP and it's high, it doesn't mean necessarily that he's leaking. It might be, I don't know, maybe a diverticulitis or just a pneumonia that increased your CRP and the abdominal exam and the abdominal pain is irrelevant. So always use your CRP in context and always trend your because it's very non-specific. When to take cultures. Pre-op cultures, rarely used. If we have someone presenting with an abscess, intra-op cultures, unless the patient is septic and we need to start antibiotics before we have source control, then we try to have cultures baseline in order for us to be able to detect the organism we are dealing with. Intra-op, whenever we have any infectious process, any abscess, abdominal contamination, maybe a possible line infection, we take intra-op cultures, and these are very important and crucial in guiding our management to our patients. And post-op, definitely whenever any patient shows signs of infectious process with high-grade fever and systemic involvement, we need to take cultures appropriately. I'm going to use a slide again in the infectious part, just because this is an emerging topic these days. COVID PCR and the COVID antigens. It has become now some sort of a guideline to test everyone before any surgery to know which precautions to take, and plus to be able to see if we can proceed with the surgery. A lot of studies recently have shown a lot of complications, post-operative complications and intraoperative complications related to COVID-19. So if someone is presenting with a positive PCR, even if they're asymptomatic and the surgery can be postponed, it is preferable to postpone the surgery because of all the complications that we are facing and that the world is describing with patients who are positive in terms of thrombosis, bleeding, pulmonary complication, difficulty with anesthesia and extubation, all of that. So pre-op COVID PCR is now recommended. Intra-op definitely has no use. Post-op only if the patient is suggestive, just because now we are in the pandemic. Now, if a patient was positive and now is free of symptoms and has negative PCR, some suggest that it's important to take the antigens to make sure if the patient's immunity is good enough to sustain the surgery and not have a re-emergence of COVID complications. No definitive studies yet, but just so far expert opinion if you want about this topic. Hematology. We come to our famous CBC. So baseline hemoglobin measurement is basically suggested patients who are 65 years of older who are undergoing major surgery, and for young patients on major surgery that's expected to result in significant blood loss. So if I have coming for a thyroidectomy, for example, young patient, 45-year-old, no previous history of blood problems, I don't need a CBC on her, except if I'm suspecting anemia, for example. Okay, so we order CBC on everyone, but doesn't mean that we are doing the right thing. So 65 is major surgery, young patient with surgery with significant blood loss. However, as I mentioned, minor surgery, unless the history is suggestive of anemia, you don't need a baseline hemoglobin, you don't need a CBC. However, even if you have suggestion of anemia and you take a CBC and you document anemia, it remains unclear if the increased risk due to anemia is modifiable by interventions aimed at correcting the hematocrit pre-op. It's reasonable to measure the platelet count when spinal or epidural anesthesia, and definitely whenever a patient is on anticoagulation, history of bleeding, or any risk of coagulopathy, you check your CBC and coagulopathy profile pre-op. Intra-op, we use CBC in case we have major blood loss or fluid shift. Post-op, definitely if we had lost a lot of blood in the operating room, we need to check our CBC and monitor it. Or if we are suspecting some sort of DIC or coagulopathy problems. For example, a patient with thyroidectomy that went well, breast surgery, lipomas. I can't think of more straightforward non-blood losing surgeries, and we don't need to monitor the CBC post-op unless the patient shows signs of hematoma, bleeding, etc. We come to the coagulation process. So routine testing is also not recommended unless there is history suggesting or anything in the physical exam or family history. The evaluation of that is suggested of with patients who you are doubting any bleeding disorder. You go for PT, PTT, platelet count, and sometimes if you have something in the history, bleeding disorder like hemophilia or platelet disorder, then there are additional specific testing for that. And this is important because if you have any suspicious that your patient's coagulation profile is abnormal, you need to test for it before you go for surgery just to be prepared. Okay, it doesn't mean that you're going to necessarily cancel the surgery. However, you need to go prepared. Maybe you need platelets, you need FFPs, you need other factors to be prepared. You need blood because you expect your patient to ooze. And maybe you need to postpone the surgery until this is figured out. So this is a very important note. Intra-op, usually we use a lot of vascular procedures whenever we give a lot of heparin for the patient to monitor their coagulopathy, their coagulation profile intra-op. And post-op, definitely if we're suspecting any disturbance, patient in the IC, a patient on heparin drip or on syndrome, then we need to follow up their coagulation profile. Duplex scan is something that I wanted to mention just because we use it a lot to rule out DVTs. And a lot of times you see us ordering it on patients in ICU. So definitely if a patient is coming from home, you don't need to have a baseline duplex on them. If post-operatively they present with any symptoms that's suggestive of DVT, then you need to assess. The only situation where we get a duplex scan to rule out DVT on a patient who's not presenting with symptoms is a patient who is not aware, intubated, in ICU, who has been immobile for a while, and we don't know the status of his lower extremities. Then we rule out DVT before deciding on which prophylactic anticoagulation to use. I need to mention one more point about the coagulation profile, especially in consumptive disorders and patients who are presenting with the IC. I don't want you to forget fibrinogen. So it's a very important factor that we need to test for and need to correct for in patients who are presenting with coagulopathies. Endocrinology system is very wide. The things that are pertaining to surgery are basically HbA1c, diabetes. So definitely no routine measurements of blood sugar or HbA1c. However, if the patient has a history, then you need to make sure that his comorbidity is in check and that his sugar is well controlled before you go for any procedures, especially to expect post-op complications in terms of wound infection, wound healing, etc. And you need to also monitor it intra-op and monitor it post-op to make sure that you are in a safe range where you don't increase the complication risk on your patients. Thyroid function test, obviously if a patient has a history of thyroid disorder or if you have suggestive symptoms, otherwise you don't need to take them routinely. PTH, I mentioned it quickly in my introduction. We use it obviously for parathyroid diseases intraoperatively the use of it is very common whenever we're having parathyroid resection to make sure that we removed the adenoma and the culprit of the disease. So what we do is we take a level pre-excision and then we take a level 10 minutes post-excision. We expect the number to drop by 50% in 10 minutes. So we are reassured that we removed the proper disease. If it didn't drop, it means either we have another adenoma or we have a hypertrophy or we have left back a part of the disease. So this is something very useful intra-op. And definitely sometimes it drops by 50%, but not back to normal. So you have to take it post-op, make sure it dropped back to normal. Cortisol level is another test we use in surgery. Very rarely pre-op and intra-op, usually post-op, especially in patients who are presenting with signs and symptoms of adrenal insufficiency, and then we go and test for that. GI system, one that really interests us as surgeons. So first of all, LFTs. Again, no routine testing of LFTs. However, if a patient is coming with known liver disease, any symptoms suggesting liver disease, patients who are coming with hepatitis, liver abscess, gallbladder, biliary problem, then you need to have a baseline pre-op LFTs to guide your management and to trend post-op. Intra-op, we don't use them. Post-op, if you had elevated LFTs pre-op, then you need to use them, to repeat them post-op to trend them back to normal. Or if you're using any drug that will lead to liver disease, so you need to monitor your LFTs, and we use it a lot whenever the patient is on parenteral nutrition, TPN, PPN. So those will lead to disturbances in your LFTs. So you need to check on your LFTs at least once a week to make sure that it's not affecting your liver. Amylase, lipase, whenever we talk about pancreatic disease. So I want to dwell on that a bit. When comparing different studies, serum lipase offers higher sensitivity than serum amylase in diagnosing acute pancreatitis. Lipase also offers a diagnostic window than amylase since it's elevated for a longer time, and thus it allows us to make use of it more as a diagnostic biomarker in the early and late stages of acute pancreatitis. Okay, so if you want to check for pancreatitis, order lipase, not amylase, because if you order both, it's not going to increase your sensitivity or specificity. So whenever you are suspecting pancreatic disease or pancreatitis, gallstone pancreatitis, for example, you take amylase lipase to root out. If they're high, you need to trend them down. We don't use it intra-op, obviously. Post-op, sometimes if we are suspecting pancreatitis due to any procedure that needs pancreatic manipulation intra-op, a lot of times post-ERCP, then we need to use them as a diagnostic for pancreatitis. Albumin and pre-albumin, I mentioned in my talk on pre-op. So this is to assess your nutritional status of the patient, especially whenever you have an anastomosis, to make sure if you have risks for non-healing and leak. Albumin's half-life is 18 to 20 days, and pre-albumin is 2 to 3 days. So albumin will assess your old nutritional status if you want, and pre-albumin will assess your more recent nutritional status. So you take them whenever you are in doubt that your patient is malnourished, and whenever you have a major surgery and bowel anastomosis, you need to make sure that your patient is ready for it, and you need pre-op nutritional support. And post-op, intra-op, we don't use them. Post-op, a lot of times, if our patient will remain NPO for a long time, they cannot tolerate PO intake, and we put them on parenteral nutrition, for example. Sometimes also it is used as an indicator if your patient is well nourished or not. Ammonia is another test we use a lot of time when we are suspecting hepatic encephalitis. Pre-op, whenever we are planning for a liver surgery and we need to assess for liver disease using some scores that will ask for ammonia level, but basically we use it to rule out hepatic encephalopathy, which usually presents post-op. Intra-op, we don't use it. I'm going to talk briefly about CT scan because we use it a lot in surgery to diagnose and to rule out a lot of diseases. So pre-op, whenever you want to rule out abdominal process, or whenever you have an abdominal process but you want to plan your surgery better, we use a lot the CT scan. You have to think properly to take the right decision and the right type of CT scan. Oral contrast, IV contrast, triple phase, CT angio. So again, have a very clear question. So if you're looking at bone, you don't need more than a CT plane. If you're looking at, for example, bowel leak, you need oral contrast to test for that. If you're looking for an abscess, you need IV contrast to define the walls. If you're looking at mesenteric ischemia, you need CT angio. So you cannot just order a CT scan because the patient has abdominal pain. You need to order a CT scan because you're answering a question in your mind, a differential diagnosis that you're looking for, because it differs on what imaging to order. Now, I just put CT here because it's mostly used and it's very handy and fast, but sometimes maybe you need an MR for a pelvic abscess that you're looking for. The MRI assess your pelvis better than a CT scan. Sometimes you need an upper GI swallow, so you cannot just throw your patient out in imaging just because you want to rule out an abdominal process. This is definitely not a good use of your diagnostics. So you need to understand what you're looking for in order for you to know what to order. Intra-op, we don't use CT scan. Post-op, whenever you suspect any post-op abdominal complications after an abdominal surgery or complicated lung disease or maybe PE, then you go for a CT scan. There's no indication for a routine CT scan anywhere, even pre-op. So if a patient comes with appendicitis, for example, which you can diagnose clinically and maybe in pediatrics with an ultrasound, this is an abdominal process, but still you don't have to go for CT scan unless you have a major question that you haven't answered or a major preoperative planning needed that you don't have a clear plan for without a CT scan. Another one of my famous and most loved quotes of House: things change. So I want you to keep this in mind. Things change, and it doesn't mean they get better. So let's say you took lactic acid now and it's 5, and then you intervene on your patient, you hydrated them. You cannot just assume that it's going to drop. You have to follow it up. You have to trend it. So your lab tests are going to change, and you have to make sure that they're changing in the right direction until they go back to normal. And sometimes even when they go back to normal, if your patient is still in a gray zone, then you need to repeat them to make sure they're still normal if you have anything suggestive that that you have any pathology or any problem. So follow up. Please trend your numbers. As I mentioned, the trend of your numbers is more important than one reading. It will tell you more about your pathology, more about your patient than just one reading. One reading doesn't make sense most of the time. Okay, because you don't know the baseline, you don't know the multifactorial things that are contributing to this result, because all tests have limitations. So trend your numbers and follow up. Don't just order a CBC today because you are suspecting bleeding and then repeat it after 2 days. You're gonna never know if your patient is bleeding or if it's dilutional or if it's just a wrong reading from a lab error. So if you're suspecting bleeding, repeat your hemoglobin every 4 hours. Repeat it every 2 hours. If you have electrolyte disturbances, correct and repeat. Because even if you gave the patient 40 mg of potassium and you expect that the potassium will be within normal range, maybe your patient has losses somewhere that you haven't yet detected and the potassium is still dropping. So follow up on your management. Make sure that you reached where you want to reach. Again, my take-home message: no one size fits all. So you need to take it by situation, take it to individualize your management, individualize your decisions on what to order, when to order, how to follow up, and when. Performing routine tests in all surgical screening tool is inefficient, it's unnecessary, and it's expensive. The value of pre-op screening lies in the clinician's assessment. So selective tests are ordered considering specific information obtained from the patients, examination, review of medical record, and invasiveness of the proposed surgery and anesthesia. The test should be done only if the results are likely to affect your management and post-op outcome. If it's not, you don't need them. They should not be guided by tradition, okay? Well, we used to do that. Everyone does that. Wrong. And it shouldn't be guided by cost alone as well. It is a misconception that obtaining a battery of routine tests provides medical legal protection against liability, or it provides you with reassurance that your patient's okay. You should know when your patient's okay and when he needs testing or not. And adopting a guideline for testing can maximize the yield and prevent waste of resources and time. However, it's very hard given the wide, diverse presentations and patients that you might face. So again, keep asking questions and try to answer them accordingly. Don't just test for no reason. Guys, I hope I answered the questions that you had and covered the part of the topic. Please let me know if you have any questions or need to clarify any of the points.
Thank you so much, Dr. Andraos. This was a really comprehensive session. I think one of the most beneficial ones. When we look back in retrospect to all the topics that we had covered, this one wraps it up and puts things into perspective. So we're going to go ahead and take some questions now. We have one already in the chat box. There's a question from Sel. How's lactic acid different from LDH?
LDH, as in lactic dehydrogenase, it has nothing to do with it. LDH does not reflect your hypoperfusion. and it does not reflect your anaerobic circulation. Actually, we don't use it to assess hypoperfusion. I don't know why you're linking them together. I'm not sure I got your question.
So Sausan expanded on her previous question, saying, I used to confuse the two. I got when to order lactic acid. When do we order LDH, though? I believe you previously answered this question, Rebecca, but you can go ahead and expand if you'd like.
Yeah, I haven't really looked at the specificity and sensitivity of LDH, but honestly, we never use it, at least in surgery. We never use it at all. So I didn't even look into it in terms of specificity and sensitivity because it doesn't answer any of our question, at least surgically. I don't know if it's used in other specialty, internal medicine or anything. It has nothing to do with lactic acid. I don't. You're confusing it because maybe at a cellular level it tells about cellular damage, but I'm not sure if systemically it reflects any of that. So we don't use it in surgery. We go by lactic acid.
All right, thank you. If we don't have any more questions, everyone, we can go ahead and wrap up the session. I'd like to thank you again, Dr. Andraos, for constantly supporting us and giving us a wonderful wrap-up, basically, of surgical management. So we
My
all
pleasure.
really appreciate that. And thanks to all our participants as well for constantly joining us and supporting us. And I hope you guys have a great day.